I need to say first that it is a wonderful progress in melanoma over the last 5 years. We were coming from chemotherapy with median survival of 6 to 9 months, and we are now dealing with survival of 2 and 3 years in median, which is wonderful for our patients. And hopefully we can cure some patients one day. So at ASCO 2015 there's highlights on targeted therapies, which is updates on the combinations of MEK and BRAF inhibitors, with median survival of now 26 up to 28 months, which is a major progress. The response rates are as high as 70%. The response duration is 13 months. So that is really something which is thrilling me, because in BRAF mutated patients we have not only one option, which is immunotherapy, but also the option of BRAF inhibition. So there is 3 trials reported. It's a trial which is called COBRIM on vemuraf and cobimetinib. It's dabrafenib plus trametinib. It's a so-called COMBI-D. And there is a premature trial, phase 1, phase 2, on so-called encorafenib, which is another BRAF inhibitor, plus binimetinib, which is a MEK inhibitor. 3 different trials, almost the same design, very similar results, very consistent data. On the other hand, we have immunotherapeutic options. And the advantage in immunotherapy at the moment is the development of PD-1 antibodies. And there is comparisons of PD-1 antibodies to ipilimumab. And ipilimumab is clearly inferior to PD-1 antibodies, namely pembrolizumab, better progression-free survival, much better response rate, better tolerability. So it's not only better efficacy in general, it's also better tolerability. So I think this is really a major breakthrough. And we will have an update on the so-called KEYNOTE-001 trial on pembrolizumab, which shows now survival over 2 years, which is in median 26, 28 months, fantastic. So it's really very promising data, and that's not the end of the story. Because the end of the story is recently released combo of nivolumab and ipilimumab, so 2 immunotherapeutic options which affect the checkpoint inhibition. And there, we have seen outstanding results from phase 1, and phase 3 will be presented tomorrow. But we have already results from a randomized phase 2, and this was a comparison of ipilimumab to ipilimumab plus nivolumab, which showed clearly superior results in all outcome parameters for the combo of ipilimumab and nivolumab. And therefore, it would not be a big surprise if by tomorrow the randomized phase 3 trial, namely ipilimumab versus nivolumab versus ipilimumab plus nivolumab, so triple arm trial, which is presented tomorrow at 1:30 in the plenary session, will come out with, again, a superiority of the combo over the single agents. That is my expectation. So we are dealing now with 2 to 3 year median survival, and hopefully this turns out to be as efficacious after 5 and more years, and so we can talk about patients cured with metastatic melanoma. Yeah, it's very clear that patients, who are carrying a BRAF mutation are candidates for BRAF inhibitors as well. Whereas the so-called BRAF wild-type patients are no good candidates because they cannot respond to BRAF inhibitors. So for patients with BRAF inhibition, we have BRAF single-agent inhibitor, we have BRAF plus MEK inhibitors, 2 different, regimens almost approved in Europe. One is already approved, the trametinib and dabrafenib in the US. So I think this is really the challenge, to bring the right drug and the right treatment algorithm to the right patients. And to be very honest, we have no clear results now. If we need to treat BRAF mutated patients in first line with a BRAF inhibitor or with a combo, or with a PD-1 antibody or immunotherapeutic combo. There is no clear data because there's a lack of clinical trials addressing this question. In February this year, there was 2 publications out on ipilimumab, the so-called, baseline immunotherapeutic agents. And it's very clear, for chemotherapy alone, you have 5-year survival of 10%. For ipilimumab alone, you have 5-year survival of 20%. And my expectation is that the PD-1 antibodies are increasing it to at least 30%. If this is not the case, and I might be wrong, I would be disappointed, because it should not be only, the enhancement of survival for 1 or 2 years. We need to have landmark analysis over 3 years, which means 3 years at least, but 5 years is better to talk about cure.